Welcome to the BCBAs Who Build, a podcast powered by Head Start Health for clinicians who believe there's a better way to deliver care in the ABA field. Here we share real stories and resources from BCBAs who have built, scaled, and supported ABA practices firsthand. Whether you're dreaming of starting your own practice or growing the one you already have, this podcast is for you. Hi, everyone. I'm Dr. Sara Feldman, and I'm really excited for today's conversation because we're getting to do something that we don't get to do very often in ABA, and we're talking with a payer. And not just from the payer perspective, we are talking with an actual BCBA who sits at the payer table. And I think this is such a huge opportunity for all of us providers, clinical leaders, and people who care really deeply about the future of this field. Because let's be honest, payer conversations come with a lot of feelings. We have authorizations, documentation, treatment plans, reviews, site visits, audits, and those are words that most BCBAs are not going to think, oh, fun podcast. But that's exactly why this conversation really matters. Because if we want to build an ethical, sustainable, high-quality ABA organization, we have to understand how quality is viewed across the system, not just in our own clinics and not just in our own treatment plans, but also from the perspective of the actual people who are reviewing whether or not care is individualized, clinically grounded, clearly documented, and connected to meaningful outcomes. Today, we are joined by Rebecca Womack, BCBA and Director of ABA at Optum. Rebecca has had a substantial career in the ABA field with roles that have helped define, shape quality and clinical standards and operational expectations across the field. Not only is she a current member of the BACB board, but she has served as a subject matter expert for the Association of Professional Behavior Analysts, APBA, represented the Behavior Analyst Certification Board on the ABA Coding Coalition, and previously served on the ACQ Standards Committee. In her current role at Optum, Rebecca brings a perspective that I think all providers genuinely need at the table. She can help us better understand how quality shows up in the treatment planning, review process, documentation, communication, and outcomes. This is not going to be a payer versus provider conversation. This is really about aligning, and it's really about how BCBAs can have a better understanding of the system that we work inside, how we can communicate with the quality about the quality and the care that we provide more clearly, and how we can keep building services that are sustainable, ethical, and truly meaningful for children and families. So with that very long introduction and your substantial background, I would love to just welcome you to the show.
Thank you so much. That was very kind of you. I appreciate you guys thinking of Optum as a payer to have a conversation with. So thanks.
Yeah, absolutely. I want to kind of just start with, for maybe those who are not as familiar, but you have had backgrounds in as a clinician. You've been in the quality measurement field from actual ABA companies as the BCBA, as an auditor and a contractor. You've sat on boards. I want to know, what do you see now from the ABA field that is maybe uniquely different from where you sit today as that payer lens that maybe most ABA providers are not going to know?
That's a great question. So I think, first of all, if you're listening and you're not board certified or you're thinking about becoming board certified, as a payer, I want to encourage you about the visibility I have into the opportunities for our science within healthcare. There's so many opportunities. And I know right now, predominantly those diagnosed with ASD have services funded most easily in our country. However, that's not the only way that our science can be useful within healthcare, and the need greatly surpasses the resources. So if you're thinking about doing it as a BCBA working for a payer, I would highly encourage you to continue pursuing or pursue becoming certified. I also think that the opportunities for us to demonstrate the credibility of our science show up as well.
Mm-hmm.
We have the chance to continue to tell the story of the power of impact that we have in the lives of those we serve. And it's exciting because healthcare is really data driven, and we love data as behavior analysts. So It's our time to shine.
Yeah. I think that's a really helpful starting point. What I would love to kind of think through, and one of the common words that I hear is this idea of we provide high quality care. So when you hear a provider or an organization say they deliver high quality ABA, what does that actually mean to you?
Yeah. So as a payer, what I get excited about is knowing that there's a basis for most things that we encounter in the industry, including quality in the literature. So most listeners may not be aware of an article that was published, I think in 2022 or 21, by Bryant and Silball on the topic
Mhm.
of quality and ABA within healthcare. And I would encourage folks to take that, read it, absorb it, and apply it, iterate on it as the framework. A lot of times the themes of conversations I'm involved with is that there's no definition of quality, and that's just thankfully it's not true. While it's a starting point, we need to continue to push the bar forward. So I think that is an example of how we think about quality. And then it's exciting to see examples of high quality treatment plans that are written in a very cohesive scientific way that shows individualization and uniqueness to the individual, as opposed to some common missteps like name misplacement and so on in those types of documents.
Yeah, I think the idea of how we determine quality and people have different definitions. A lot of times I run into people who are saying they measure quality, but they're really talking about operational like fidelity and those, which is very important, but maybe not quite the same thing. What do you think that providers or BCBAs often mistake for quality when they say we have quality, but it's not maybe a reliable indicator of what care should look like?
That's such a good point. So, what you mean when you say it should be established first. So, when it comes to quality, you're right. Like, I think I'll start by saying my definition aligns with, and my as a payer aligns with how it is defined in literature, which is first
Mhm.
of all, considering and understanding the standards of care. There is not just one source, but there are many sources within our profession published by the different associations and organizations around what standards should look like given the context. And so that as a framework then becomes a stepping stone for the provider to demonstrate in whatever aspect they're talking about, whether it's telehealth or use of AI or assessing a client, what quality should look like. And then based on that activity, collecting data or having metrics around that data point.
I think it's so exciting to hear about the fact that there is a real clinician, a real BCBA who uses the research and uses that to inform kind of your daily actions at Optum. That it makes me feel like I have somebody on the inside. Like we know what these standards are. It's not like the literature is guarded. We have access to that. We can have like a common language, and it feels like that's a lot of what your role is right now at Optum, of just kind of we're all speaking the same language, but or saying the same thing, but not maybe speaking the same language. How do we all get on the same page? And that was something that really resonated with me when you were chatting in CASP and really talking about like, look, we're all saying the same thing, but how do we get payers and BCBAs to be on the same team and say the same language and words at the end of the day?
It's such a good point. And I think, you know, because we're analytic, behavior analytic is part of the
Yeah.
description of our science. We can complicate simple things, but it really is not that complicated. It's more process based. First, it's understanding what the standards are, what they talk about, and then not just assuming because you know the words that you can put to application or your behavior can demonstrate those standards across settings, times, relevance, and so on. And I think that's where there is an opportunity for providers to have input, whether it's a supervisor or a consulting committee come in and say, we understand the standards, we're able to measure that and give you feedback about your accuracy in how you're delivering this aspect of quality care to what degree.
Yeah. So, okay, then I think there are so many opportunities in which, and I think Optum does this really well, of you have a lot of eyes on the different parts of an ABA organization. I know years and years and years ago when I was looking to join the Optum network, I had a site visit. And I remember preparing for that site visit. And then, from there, we have treatment plan reviews and things of that nature. From the payer perspective, when you're looking at a provider's organization from that bird's eye view, what starts to cultivate trust and maybe confidence just at the very beginning when you're like, okay, this feels like maybe this is a good organization. Things might be going okay here.
Well, that sure your listeners are appreciative of that question because that is also on our mind when we go into these site visits, meaning um, prior to even visiting, we recognize that we're not just coming in because we have a basis to, the contractual relationship, but we're coming in to your environment that's a disruption to your operations and systems, but more importantly, to the members that you're serving or the clients that you're serving. And our desire is to have as little touch there as possible so that the disruption can only be beneficial if, in every way
Hmm.
intended, as opposed to anxiety provoking, stressful. And so this is why we're working on, just as a caveat, like making sure that we are managing expectations from not just even the time leading up to the visit, but the visit itself, level setting on what the visit will look like, what the conversation will look like, and then moving on from there. But in terms of like those quality attributes or the things that, we get excited about when we see, it's nothing out of left field. It is things that we all should be aligned on, which is a culture where the employees appear to be happy, engaged,
Hmm.
that they're productive in their work. The environment is well suited to services. It has the right resources for the populations that are receiving treatment. It's set up in a way that's conducive to care as opposed to not being set up well or being a little bit chaotic. And then when we have conversations with the people who work there, that they're easily able to say what should be done when, what it looks like, and they have the ability to demonstrate that.
You've been listening to the BCBAs Who Build podcast, a place to learn, grow, and find freedom in the ABA world. If you've been considering starting your own ABA practice and taking your career into your own hands, reach out to us today at headstart.health. Our team of BCBAs can walk you through the exact steps you need to turn your goals into reality. Career autonomy is only one click away at headstart.health.
I would be really interested to know when you're looking at those treatment plans, how, from a payer's perspective, are you seeing if something is thoughtfully created and it's child and family centered versus some of those things that maybe kind of give you some yellow flags, orange flags, maybe even red flags that this is formulaic, this is not individualized at all?
Sure. So it's exciting to report, the things that we see that get us just thankful and grateful for the services that clients are receiving based on the plans we see are plans that clearly indicate the provider has thoroughly evaluated the family's needs for seeking services and has woven that need into the treatment plan. So they've captured the reason for referral, they've captured the family's priorities for treatment. And not only that, they've woven those activities into their assessment planning, and then they pulled the thread to the treatment plan development. So there's goals that roll up into those eventual skills with evidence that the child is working towards that over time. And if for some reason those goals drop off, it's because the family's priorities have changed. And that's all clearly documented in the treatment plan. Where I think there's, elements that give us pause or cause for concern is when the plans themselves don't clearly connect the assessment to the goals. So the assessment
Mm-hmm.
might evaluate even measures. I've seen a older child, a teenager. I've seen situations where the assessment doesn't match to the client's profile. An example could be having a teenager be assessed with a VB map while the teenager may have attributes that would lend to a better assessment. And
Mm-hmm.
it seems like the assessor is just taking a template approach, like we're going to use a VB map, know what, better what, as opposed to looking at the needs of the child or the client themselves. Other indicators are that, with the client over time, if there's goals included in the treatment plan and graphs are included, that there's clear documentation about the efforts to optimize care. So
Yes.
whether that
Okay.
be evidence of phase lines in response to data trends that are not favorable or stagnant, or there's documentation about protocols modified over time to ensure that the impact of ABA is having the right effect. When those things are absent and we see a lack of progress in just continuing goals into perpetuity, it gives cause for concern about where treatment is heading and what the point of care is.
I think that's important. The idea of like what's the point of care? I I've worked with a lot of BCBAs over the years, and some come with lots of different learning histories on how to write treatment plans. Some come with no learning history on how to write a treatment plan, depending on where their supervision is. And we always talk about this concept of like the so what factor. Like, what's the purpose of entering into ABA services? And it cannot be to match or to be able to match all the boxes on the assessment or check them all off. There has to be a greater need or a need that the family is seeking in order to support quality of life and have so what that you can do 30 feature function class type things, but if you can't walk across the street safely or know the difference between that's hot and we should not touch that versus or building independence, having that permission to have clear through line rather than saying my goal of ABA is to fill in the boxes and to continue with progress and that manner and measure progress in that manner. There's so many other ways that we should be measuring progress from there. So it makes me feel good to hear the idea of like there is that through line of the caregiver and the social significance that goes along with it.
Yeah. One thing, if you don't mind, I'm going to add that
Yeah.
comes to consideration is the fact that there is a cost to care. And I'm going to explain that in a second. I think as behavior analysts, I can certainly identify with being very protective of our science and very protective of the research, the credibility of what we do. But I don't think we always put ourselves in the shoes of the family or the recipient of services. So if we looked at like just from a
Yes.
90,000-foot view, and we calculated the co-pays over time and the time that family spends waiting for care, late sessions, or things that just don't always go as planned. And then maybe we quantify the emotional investment. Now, if we looked at that as a total sum across those different buckets of relevance, it might land on this differently what the family puts forth when they say,
Yes.
yes, I'm going to have my child be treated here. It's a huge weight of responsibility to go in. And I think I say we as providers, so the behavior analysts, but providers themselves need to think about the opportunity to optimize on that investment to give the family the best possible return they can as quickly as they can so the child can go on to a life of meaningful independence.
I love that. The life of meaningful independence and as quickly as possible. I think those are concepts that I wish more BCBAs would understand. Our job is to work ourselves out of a job. We would like to be able to do that as quickly as possible. We can work on everything under the sun, but should we work on everything under the sun? What is truly the most impactful thing in order to support the family and to support the individual that we're serving? And I love that idea of what you said of there are so many other ancillary pieces of impact that come along with this that I think most BCBAs are probably not considering. I'm not thinking about how far a family is driving, or if they say yes to ABA, what are they also saying no to at the same time?
Yeah.
So I love that lens. That's so helpful. I wonder in that same idea, and we're looking at these treatment plans, we're looking for the through line, we're looking for meaningful change in our treatment plans. What do you feel like is the most misunderstood thing when it comes to how care is reviewed and how it's determined of who gets to have access to ABA services or who gets to continue on care in the proposed model? What do you think we're kind of just maybe we don't understand about that?
I think one of the common misconceptions is, and I speak from, having been a provider and a consultant, so working with a lot of different organizations, that the motive for authorizing anything less than what was requested is financially driven, when in fact, there's such close alignment between providers and payers around the priority of care. And the priority of care is to deliver what is medically necessary for that child. Where things get kind of confusing is if, there's differences in opinion about what that looks like or how that should be showing up in a treatment plan. But I think, having been at Optum now for quite a bit, it has been such a joy and pleasure to see how passionate my colleagues are about ensuring that the members coming into contact with providers who can deliver exceptional services and can do that sustainably in a way that speaks to the family's need for treatment.
I wonder if a BCBA is, and this goes off book, and so I'm sorry, but I am curious when you're in the moment and you're doing your authorization and you have a peer-to-peer and there's that discrepancy of how maybe that individual is measuring medical necessity and the individual who's conducting the peer review might have a different lens, and that how can BCBAs work best together in that moment in order to make sure that client priorities are served at the highest level?
Yeah, this is it's a it's a really good question because I think a lot of people are probably saying like, yes, I've had this moment or my supervisor had this moment. And I think the first thing is self-awareness. And by that I mean being aware of how you're thinking about the situation. Are you open to the fact that you might have an opportunity for improvement? Because I think oftentimes we expect the other person on the end of the phone to be aware of the fact that they are wrong. And they might be wrong. Like I am amazing at making mistakes. I've made mistakes in the past, and I'm certain that there have been times where Optum could have improved maybe how they looked at something from a treatment plan perspective or a peer review perspective. But I also can say, having reviewed countless plans over the course of my profession, there is opportunity for providers to clarify their writing, to ante up their clinical documentation, and to make sure that they are really threading the needle of medical necessity in a way that's individualized, concrete, and is linked to what the ask is in a way that they can explain to the payer, as opposed to saying like, well, here's a stack of articles, maybe it is peer reviewed and evidence-based, therefore it should be approved. And I don't mean to oversimplify, because I know it's more complex than that, but I think it starts with just doing a self-aware or being self-aware first to see if you've done your part.
Self-awareness, I mean, it's the first step to leadership and self-guidance, is that, so it's I think that's really important because I've had plenty of peer reviews over the years, and my first response is to armor up in a sense of like, you're going to point out a flaw. And, and so I think our very first idea, I mean, and, to our listeners, Rebecca has reviewed my own treatment plans before for my previous company. And there are moments in which I will speak for myself that you armor up because you feel exposed and you do those things, but it doesn't serve us well in order to look at it from the lens of I'm right, you're wrong. There's nothing more I can learn in this situation, because our kids and our cases are really complex, and I think that's something that BCBAs in the ABA field can really learn from, is this idea of collaboration, especially on case conceptualization, and being able to say, hey, I haven't had access to mentorship or support on this. And so I'm going to take the feedback as an opportunity to collaborate and to learn more. But I can definitely say I have bucked up. I've really bucked up at the idea of, no, this is really this, I'm right, you're wrong. And so what a human experience. But I think that's a really great, helpful point of let's first start with ourselves and really look inward.
So can I just say one thing to
Yeah.
encourage you in that, and to your listeners? I, over the course of my profession, have had the privilege of having my work reviewed by people way smarter and way more gifted at writing than I am. And I know that feeling. It feels crushing, and your initial gut reaction is to be defensive and to say like you're wrong. But with time and space and just being able to see what I learned from those reviews, that helped me far more than praise or compliments. And I'm not saying that that's what a BCBA wants, but
Yes.
learning from the mistakes was far more valuable, and I still carry those lessons with me even till this day. So my encouragement is just to see it as an opportunity like you described.
Yeah. I think another thing that we see too is a lot of BCBAs are moving through the field and moving towards licensure and certification a lot faster than some of us previously that, went through long periods of supervision, and it just looked different. We had to work harder, different in a different manner in order to access those supervision. And so, in the absence of having a clear mentor, I think you have to be scrappy to find different ways of getting that feedback. So whether that be listening to podcasts or reading books or reading literature, or taking moments to self-reflect when somebody else is able to actually look at your work and ask questions and say, I wonder about this, and can you help me? It's sounding like it's not necessarily that we're going into this authorization looking to poke holes, but we're looking to seek understanding and to find some clarity in just question marks that naturally come up because we all approach problems in a different way. I want to zoom in even more a bit on this idea of, okay, so there are these standards you've mentioned. When we're writing our treatment plans, we're looking for that through line, being able to have some commentary between family outcomes and what it is that they're looking to achieve. We are looking for phase lines and really, or phase change lines, and really making sure that there is thought and care that's put into this. I come in contact with a lot of BCBAs who feel stuck. They are part of a system. There is something that is expected. There are rules within their system or the company that they work for, and they want to do something and they want to move forward. They want to learn more. They want to increase their quality. So I wonder, what would you say to that BCBA who feels like they're trying to do the right thing, or they think they're trying to do the right thing, but the system that they're operating in right now does not always make that feel easy?
Yeah. So I think the first thing that comes to mind is that I just want to acknowledge how hard it is to become a BCBA and to maintain that credential. Like, it's not just the cost of school or the work that goes into being supervised or prepping for the test and passing the test. It's also navigating that role within the healthcare system, which none of those attributes are really directly tied into, like, discreetly tied into our task list. So I know that there
Mhm.
are some academic programs out there that are weaving those elements in, and to your credit, that's amazing. But it's probably fair to say that most providers didn't get, a class on medical necessity in their career. So if you're like, this is hard, that's okay, because it is hard. It's hard to do something that you didn't maybe have direct education about. And so that said, the other thing that, is exciting about ABA is that it's a science based on the literature. And the literature was not created within healthcare. It was created within university settings or research systems. So the practices that we're building, our business models off on structured time differently. But interventions and the processes are linked to what is freely available, which are the standards of care. And so the encouragement is to, first of all, be kind to yourself, to know that this is hard. It's difficult work. It's exhausting. And even though you might feel like much of what you do goes unseen or unacknowledged, if you stay faithful to the small things and you build fluency in those skills before you spread your wings and go further, you come from a much stronger base that will serve your clients well or the service recipients well over time. But then you don't have to reinvent the wheel. You have the standards of care that are linked to our literature, which often refers to, we're not trying to create anything different. We're, happy to defer to that so that you have a pathway along treatment on how to conduct your activities, whether they're operational or clinical. And I would say the final, thought around that is making sure that while there might be a financial aspect or formula to how that works out, it is also important to make sure that the clinical activities associated with that formula are aligned. Because if they're misaligned, then you get overwhelmed folks at minimum and difficult days out of that. So
Yeah. I wonder, and this is maybe, it feels maybe on the heels of a lot of what's been in the media about ABA organizations right now, but do you feel like our current ABA landscape is actually truly set up to reward quality, or is it more set up to reward compliance and operational consistency?
it's a great question. I think one thing I want to say about the articles that are, which this just as an aside, the articles that are popping up right now is that I recognize that just because one provider, one situation occurred, does not mean that it tells the story about all ABA providers or even that whole organization. So I think there's some sensationalism around what's, being published right now. And so we're still just looking at every individual provider and it's a clean slate. And so when it comes to what you asked about operational consistency and compliance versus quality and what is rewarded, right now, a fee for structure schedule is more compliance focused, but what we are focusing on is pulling out and elevating those attributes of quality to better understand how care is best affecting the members getting treatment. So that goes back to what we've been saying this whole time, which is, what did the standards say? What does that look like in terms of metrics? How can that be woven into elevating or highlighting those providers who are doing those things and have the data to back it up?
There's a growing movement, and you mentioned this concept of, value-based care. I think it's a hot topic. It's a hot topic word. People think they know what it means. They may or may not actually know what it means. But anytime somebody has the opportunity to say, well, I work really, really hard and I've got good outcomes, maybe I should get paid more. Maybe I should go to the front of the line, or whatever that happens to be. I think that becomes something, a bit of a buzzword. And so as a field, I feel like, we do have the article that we've been talking about here, where we can start to define what quality based care might look like, or the outcomes. But when you think about that idea of value-based care, what would need to be true about quality and measurement of outcomes and things of that nature in order for this to even be a topic that we should approach as a field?
Yeah, I think it's starting even more granular than that. And it's before having that discussion, it's the providers who know that the services they're delivering by the RBT, or if they have a solo provider model, that those services are run with fidelity to the treatment plan, to the technological aspects of however the clinical framework is in their organization of what a good session looks like. And they can do that sustainably over time, because that core becomes the pillars of value-based care that is built on. So after that, the organization should be able to capture that information in infrastructure that can be bi-directional, whether it's between you and a payer or you and other stakeholders. So you can say, hey, here's our buffet table of amazing data, not just in terms of the quality of services we're providing or the oversight we're delivering, but we have the ability to also show you the outcomes. We are a phase line in the lives of those we serve, and here's our impact. And then that then becomes that framework of, okay, now that I have the capabilities of doing this and I'm on a fee-for-service model, what is my business model? Where is there leeway in a model for me to improve the sustainability of care? That doesn't necessarily mean a jump to value-based care. There's many different types of reimbursement models between there. It's a kind of a ladder. And so I would say it's a crawl, walk, run type approach. You want to make sure that before you switch your whole infrastructure to a model that you've heard about and sounds amazing, that you have the capabilities of doing maybe less structured models like that, and more updating yourself or shaping up your performance to get to that point, so you can sustain quality and outcomes over time as you shift the way you think about treatment.
So what I take from that is, first, that idea of, can you even define what it is about what you do that makes it effective? And it can't be even, it can't be this concept of, well, I do ABA and I follow ABA. Like, that's not that's not what we're talking about here. It's, can you actually operationally define how your model is distinctly different, or how it is implemented, and you can say that reliably it's going to happen across each individual that your company would interact with. And so I think that could be a humbling adventure, to sit down and actually say, do I know why what I'm doing works, and could I replicate that for another family?
Yeah, because this is also, I want to give a caveat out here. This is a gross oversimplification of all the considerations. So
Yes.
if you're like, I have my punch list ready, go, like, pause. That is a part of the conversation. Another part of the conversation is, can you stratify your case mix of clients so that you can demonstrate impact accounting for band of age, acuity, length of care, and then roll that data up into a way to share with interested stakeholders. And if that sounds impossible to some, I want to encourage you, it is totally possible. There have been several providers that we've had such joy seeing this very type of data. And it's data not just around ASD, it's around the whole health of the child. They are not a diagnosis, they are a person who has a diagnosis. And so it's great to see the other metrics about their life that change as an effect of ABA, and not just in treatment, but as they go through decreasing treatment, through discharge, and then after discharge. The organizations are able to say, this is their life, or these are our data points on what things look like post care 6 months or a year down the road.
With this concept of value-based care, I hear it on the horizon, but to even think about this more broadly, looking ahead, how do you see expectations about how we define quality, or what quality looks like in ABA, over even just the next 3 to 5 years? There's a lot going on right now.
I think that in order for care to be sustainable, first of all, this has to become a much more crisp conversation for the profession. So the profession, in my opinion, doesn't necessarily have to have uniformity around the metrics they consider quality because we are behavior analysts first. And so social significance matters, right? Like if your organization serves a type of client or clients that receive a certain type of care, some quality metrics or outcome metrics may not apply. And so it's important for you to be the steward of the services you're delivering and to evaluate in the context of literature what care looks like. And I think as organizations take the initiative themselves to do that, to collaborate with other like-minded professionals, it'll be this type of ripple effect where there's concentric circles overlining across time. And that framework will be able to build on itself because like-minded people are then saying the same thing and sharing the same type of data. So I think if you're thinking, wow, this could be me, and that interests you, that's your SD to reach out and make sure that you've got your things in check, you're self-aware, and then to search for other like-minded professionals to help you pursue your passion in this conversation around value-based care.
So every episode we wrap up with this concept of a permission slip and really giving our audience this opportunity to take a piece of advice or guidance from our guest. And so I would love to hear a permission slip that you have that maybe you would tell to a provider who's maybe on day one of thinking about what could I do to make my service higher quality, better impact, more sustainable?
I think the permission slip is to not pursue perfection, but to pursue excellence. And the difference is that excellence carries attributes of being self-aware, of course correcting, of being a steward of what you're doing, of recognizing impact, and of helping those along the way. Pursuing perfection is about self, and we're a human service profession. So I'm encouraging you to give yourself permission to pursue clinical excellence as a provider and give yourself grace when it doesn't go as you expected.
That's so good. There are a couple of standout quotes that I feel like I have written down. This idea of we're not pursuing perfection and we need to start with ourself and that self-awareness of what's this bringing up about me? What is it telling me about myself here? It's not necessarily saying that I'm wrong, but maybe there's an opportunity to learn. And this idea of collaboration, and that in the future, this field, our field, the ABA field, must become more collaborative. We must be sharing notes on how we do what we do and why we do that. And really, it all comes back to this idea of really great, high quality care for families because we are, in fact, just a phase change in the lives of the families that we serve, which I think is chef's kiss, a perfect quote that I will now probably take as much as I possibly can. But I really appreciate your time today and the lens in which you are able to share your experience in ABA. I think it's eye-opening for me. It makes me definitely lower my affective filter when it comes to how we interact with payers and who is sitting on the other side of the phone call or that payer guideline. So thank you so much for your time today, Rebecca. I greatly appreciate it.
Thank you. Thank you for the conversation. It was a joy.
You've been listening to the BCBAs Who Build podcast, powered by Head Start Health. New episodes drop every second and fourth Thursday of the month. And as always, you can listen on Spotify and Apple Music to stay connected and hear more conversations around ethical care, leadership, and what it takes to build a better future in ABA.